Welcome to the Healthful Woman podcast. Today is Monday, April 5th, 2021. On our podcast today, I'm joined by Dr. Erkan Buyuk from RMA of New York to discuss pregnancy with an egg or sperm donor. On Thursday, we're going to have a high-risk birth story, and then next week on Monday, social media sensation Adi Heyman will be joining me to talk about empowerment through modesty. Thanks for listening, everyone. Have a great day. Welcome to today's episode of Healthful Woman, a podcast designed to explore topics in women's health at all stages of life. I'm your host, Dr. Nathan Fox, an OBGYN and maternal fetal medicine specialist practicing in New York City. At Healthful Woman, I speak with leaders in the field to help you learn more about women's health, pregnancy, and wellness. Okay, I'm here with Dr. Erkan Buyuk, who is a reproductive endocrinologist at RMA of New York. Welcome. Thanks for coming onto the podcast.
Thank you very much, Nathan, for having me.
This is wonderful. So we're going to be discussing today egg donation and sperm donation, and you run that program for RMA, correct?
Correct, yes.
Very nice. So first, tell us a little bit about your background, sort of where you're from, how'd you get into medicine, how'd you get, here to the US and into infertility treatment?
Sure. So I am from Turkey originally, did my medical school there for 6 years. It is different from United States. And then after medical school, I went into OBGYN, 4 years of residency.
In Turkey?
In Turkey,
So
yes.
10 years?
10 years, yes.
Okay.
And then I worked as an attending for 1 year. In between, I did my military service for a month. And then, I came here. I actually came to Cornell. Where you are, where you were, for a research in REI. And then I did 3 years of research. I was
at Cornell.
At Cornell and Memorial Sloan Kettering.
Right. And did you always know you wanted to come to the US, or did something change that you said, I want to leave Turkey? Or how'd you make that decision?
So that decision was seeded in our brains in high school.
Really?
I am actually from a French high school. But when with my friends who were geared towards to do medical school, we were always talking about, how opportunities are so great in the United States, especially science and research.
Right.
So when I started medical school, I took the USMLEs almost right away.
Right.
At the end of the second year, the basic sciences. At the end of the fourth year, the clinical. And then it was always in my mind. But then I got married at the end of the medical school. And then, my wife also always wanted to come here. But we still did our residency there. There was no opportunity at that particular moment.
Is she a physician also?
She's a physician too. She's a cytopathologist. When the opportunity came up, at Cornell, for a research opportunity, we took it. I came here first. 6 months later, my wife came. Actually, I came mainly to do research and to do some basic science.
Right.
That was my main. Over there, I was working as an attending. I had a nice life, honestly.
Sure.
But, the science and the basic science was missing.
Right.
And I was always research oriented. I was working in a clinical job. So it was not very satisfying.
Right.
So after I came here, I worked at Cornell, and also I was doing ovarian freezing and transplantation at Cornell together with Dr. Oktay. And then I was also doing some basic science research at Memorial Sloan Kettering at the same time.
Which is right across the street, basically.
Exactly. So it was very convenient.
Right. And at Cornell, obviously, for our listeners who don't know, has a very well-known reproductive endocrinology and infertility program clinically and also research.
Exactly.
Meaning both. So that was a very strong program to come and work with for several years.
Exactly. It was at the forefront of IVF and REI. So it was very rewarding experience. After 6 months, I told my wife, I don't think we should go back. Why don't you come?
Right.
She was also working at the same time. She was dermatologist over in Turkey. And then she resigned. She came. So, and then, we stayed. After 3 years, I said, since we are saying we have to do residency again.
Oh,
so I did another residency.
Yeah, that must have been pretty tough to redo a residency in the US after finishing and also, practicing already in Turkey.
That's right. But, it is tough, but it is easy at the same time.
Okay.
Because you know most of the stuff.
Right.
So it is, it is not as challenging as you are an intern from out of medical school.
Right. I guess that's fair. Where did you do your residency?
I did at Maimonides.
At Maimonides.
Yes.
And was there anyone else like you in the program who had already trained and went through medical school elsewhere, or were you the only one in the program who had sort of gone through this before and you're with all these people junior to you?
So there were, there were, for medical graduates,
right.
I wouldn't say some, I would say one or two, maybe, at that same period. But after I left, there were others who came, who did it before, and then who do it again. But I think it is worth.
When I was a medical student, I remember there was, not so in my class, but there was an intern on the surgical rotation where I was, and he had already been a surgeon in South America for he's like a brain surgeon for like 5 to 10 years. And here's this guy's he's like a really, really good surgeon. He's got tremendous skills. And here he's doing his internship. This poor guy, he has people, 10 years younger than him, bossing him around, telling him, change that dressing, check that lab, do this, like they do to the interns. And I was just like, my God, what he has to swallow every day to not just, come out and say, you don't know anything. I'm smarter than all you people. Did you have that? Was it hard to sort of come in and be even the bottom of the totem pole, even though you know more than all the people sort of training you?
So the truth is, first I didn't care. And also, I have been in their shoes before.
Right.
So I know what they are expecting from me.
Right.
It doesn't care what I know.
Right.
What is important is, what they think is right.
Right.
If something is obviously, overtly wrong,
right.
Of course I remind them.
Right.
And they were very nice in general.
Right.
Even sometimes the attendings were asking me,
right.
Calling me to delivery, do you think she will deliver? So it was, very collegiate and nice. I didn't feel like, you don't know anything.
Did you know at the time you started your residency that you were going to do infertility afterwards? So you're like, I'm going to do residency, I'm going to do fellowship, I'm going to do this, 7 more years. Here we go.
Correct. I came here to do infertility, actually. That was eventually,
right.
if I were to stay, if I could not make it, I wouldn't stay here.
Right.
Just a regular OBGYN. I can do the same thing over there.
Right.
But there was no formal training in REI in Turkey.
Wow.
So I wanted to get a formal training.
Right.
And then, otherwise, most likely I would not have stayed. I don't know, things might have changed. But that was my main aim.
Right. But it's amazing if you think about it, it's 20 years because you did 10 years in Turkey. Then you had the year of practice in Turkey and then 10 years here, 3 years research, 4 residency, 3 fellowships. That's 20 years plus 1 in the middle before you're practicing. It's good. So you got to stay in good health so you can work for a long time.
Exactly. I'm not planning to quit anytime soon.
Yeah. Okay. And so you finished your residency and then you did your fellowship in REI where?
At Einstein.
At Einstein, right. And that's where you were until just recently, correct?
Yes, until the end of 2019.
End of 2019.
Yes.
Wow. And so here you are at RMA New York, Midtown Manhattan. How's that going for you?
It's great. It is very intellectually stimulating. Great colleagues, a lot of patients, a lot of pathology, high volume. It's nice, very nice.
And how did you get interested specifically in egg donors and sperm donors?
So over at Montefiore, when I was practicing, when I finished my fellowship, I stayed there.
Right.
And then, I had interest in donors, basically in general. We had Dr. Christina White, who was overseeing that program. And she said, do you want to take this program over? I said, yeah, sure. I had already interest in it. I learned from her and from Dr. Harry Lehman, who was the director of the practice. After a couple of months, I took over the program.
Just so we can understand, get some background on the whole concept of egg donation, what is the main reason why someone would need an egg donor? Why someone would need to be the recipient of an egg donor in order to get pregnant? What are the main reasons?
So the main reason is what we call diminished ovarian reserve. Basically, lack of eggs. So that particular woman may have primary ovarian insufficiency where, it happens before the age of 40, basically very minimal amount or no amount of eggs left. These patients can still get pregnant on their own. However, within their lifetime, there is a roughly 5 to 10% chance of getting pregnant.
Right.
But you don't know when it is going to happen and if it is going to happen. Doing IVF or any other treatment for these patients does not increase the chance over the baseline.
Right.
So there's really no treatment for them to get pregnant.
Right.
Donor egg is a very good option.
Right.
Because it gives them, I would say 50-60% chance of having a baby.
Right. That's per cycle, basically. Yeah. So meaning if they keep doing it, it's going to work.
So that's one. Diminished ovarian reserve, advanced age.
Right.
Somebody 44, 45.
Right.
The chances for pregnancy, even with IVF, is very low. So they would need donor egg. So basically lack of eggs.
Right.
Who else needs, gay couples.
Right.
Will need donor egg.
Right.
For obvious reasons.
If they're 2 men.
if there are two men, exactly.
Correct. Right. And then I would imagine the most common reason must be women who are in their 40s or 50s who are trying to get pregnant in your practice.
That's correct. If they are closer to 40,
right.
then, it is worth doing IVF.
Right.
It's if they are closing to 50,
right.
we don't, most of the time, we don't even try.
Right.
If somebody is 48, 49, 50, it
right.
is very, very unlikely that they will get pregnant with their own eggs.
Right.
So donor egg is a great option for those women.
How do you decide with them? Like, let's say, if they're closer to 40, usually they can use their own eggs. If they're closer to 50, usually they can't, or almost always they can't. How do you work the break point? Like if someone's 43, 44, 45, 46, is it just, you do blood tests, you give them percentages and give them the choice, or do you have hard cutoffs in how you counsel people?
So there is really no hard cutoff. It is a discussion between the physician and the patient after determining their ovarian reserve with a battery of tests.
Right.
So, at the age of 41, 42, it is, just off the bat, it is, without looking at anything else.
Yeah.
Average 12% per cycle live birth rate.
Okay.
If this is above 42, it is quoted as 4 to 6%. However, that 4 to 6% is most likely the ones that are closer to 43 and 44. And as you get older, it gets less and less. If somebody is 43, 44-year-old, but their ovarian reserve testing shows that, eggs numbers are minimal. We do the sonogram, we barely see one follicle, let's say. In those cases, it is hard to put this patient through an IVF cycle.
Right.
It is a lot of counseling, regarding the low success, and then recommending more towards donor egg.
Right. Now, but if you had someone, let's say 43 years old, but their tests are really good and their ultrasounds are really good, you would counsel them differently, obviously, because they're behaving like someone not of their average age.
Exactly. In that case, there are two things that we discuss. One is the quantity of the eggs.
Right.
You have very good quantity of the eggs.
Right.
But the quality of the egg,
which
is the chromosome number, basically, is still for the one who is 43. It is not for the one who is, 33, for example.
Right.
So the majority of the eggs are going to be still abnormal.
Right.
But for that particular person, let's say at the age of 43, 85% of the embryos that are formed from that woman and her partner or the sperm donor is going to be abnormal.
Right.
However, in theory and statistically, if you have a lot of eggs, there is a possibility that one of them is going to be normal.
Right.
So that person is going to have most likely a better chance than someone who has only one follicle, for example.
That makes sense. Yeah, no, that makes a lot of sense. Do people ever do egg donors to avoid genetic diseases? Is that something people do sometimes? Like if they carry a genetic disease and for whatever reason it's not amenable to them, testing the embryos of this. Do people ever do egg donors for that reason?
Absolutely. For the ones that have mitochondrial diseases, for example.
Right.
Mitochondria for the embryo is going to come from the egg, basically. Right. And then if those are carrying the disease, then the best way to eliminate this is, using donor egg.
Right. And then what would be the main reason someone would need a sperm donor?
So sperm donor, a lot of possibilities. One, heterosexual couple.
Right.
The male partner has azoospermia.
Right.
And we cannot get any sperm from the testicles. For example, Sertoli-only syndrome.
Okay.
Where there aren't any precursors of any of the sperm.
Right.
Okay. So that's one.
Right.
One indication. Single woman.
Right.
One of the most that constitute one of our population.
Right.
Lesbian couples.
Right.
Okay. They will use donor sperm.
Right.
So
and I guess also the same thing. Are there any genetic situations where you may have a sperm donor? I mean, the only thing I could think offhand is sometimes, if a woman has like based on blood type or something, and it could be very complicated, with antibodies, but that's probably not as common.
It is not as common. Yes,
right.
It should be very rare cases. I don't remember having, for blood type income because of the ROGAM, that's so rare.
Right.
I don't remember any of my patients, but it could be definitely an indication.
And so as you have someone, either an individual or couple who comes to you and they need a donor, how does it work with getting an egg donor? Right. So let's start with them because that's a little more complicated than a sperm donor. Right. So then egg donor, how do they find them? How are they recruited? Who are these people who are donating eggs? How does that process work?
So egg donor can be done in couple of ways. One of them is anonymous versus directed. Directed means somebody is using eggs from someone. It can be a young sister, often, a young niece, a young cousin, or a young friend. Or it can be anonymous, somebody they don't know. So, and if it is anonymous, it can be fresh or frozen. Frozen means like sperm banks, we have egg banks now. So women donate their eggs to those banks, and those banks, distribute those eggs to clinics, for those women. Or it can be fresh. For the fresh, it can be either recruited through an agency. There are donor egg agencies who get the stories of these women, and then they put their profile on their website. Or clinics like ours, or the clinic that I was working at Montefiore, we also used to recruit our own donors. Okay, you give advertisements, and there is an egg donor, universal egg donor form that they fill in about their history, medical history, their interests, of course, their physical characteristics, etc., ethnicity, race, and then we review those, or the egg bank reviews those, or the agency reviews those, and then if they are compatible, then they undergo a psychological screening, and if that's fine, then we do what we call FDA screening, infectious disease screening, that is done in FDA approved labs. And if all the tests are negative, then that person, that donor, is eligible for donation. We do the same testing for directed donors as well. They undergo through the same process. There is a small difference between directed donors, though, even though they come back positive for something, for an infectious disease, for example. The embryos are still ineligible, but they can still be used for donation since they know each other and they want particularly that person. As long as the recipient knows that, let's say it is positive for an infectious disease, for example.
Understood. And then when the donors do it, I mean, the process they go through for the donor is as if they were going through IVF, but it sort of stops after the eggs are collected and then nothing happens. They go home, they're done. And if it's an anonymous donor, they're recruited just through advertisements, and people do this because I guess it must pay well, right? What do they typically get paid, the donors?
I don't have the exact number, but it may change from one side of the country to another, from one clinic to the next, or from bank to bank. But they are being paid in general around $8,000 to $10,000. This may be less again, down to $5,000 in some other.
But it's thousands
places.
of dollars.
Thousands of dollars, that's right.
And because they have to undergo, obviously it's a lot of time, and then they get injections and there's procedures. But is this something where nowadays there are a lot of people who are, willing and able to donate eggs, or is it something that's very hard to find? Like, what is the sort of the supply for egg donors?
So it is not that hard to find. There is financial incentive. However, they, like you said, they go through, through injections for a period of 10 to 14 days. They go through all this screening, and then they undergo a procedure, egg retrieval, which is under anesthesia. So they go through a process. And some of them are doing it because they had somebody who was suffering from infertility. So, they have compassion. It is not just the finance, but, they really want to help, other couples. It is not that rare. We can find, it is not like, for example, gestational carrier. Gestational carriers are much harder to find. But egg donors are not that difficult to find.
And in your practice, ballpark, what percentage of them are anonymous versus directed donors, would you say?
I don't know the exact numbers, but majority are anonymous.
Majority are anonymous.
Yes, directed is much rarer to find. So each has an advantage and disadvantage. For example, the advantage of the directed donor is if she's a relative, then you share some genes. So that's one of the main reasons why people prefer. It may be less expensive because it is, almost completely compassionate.
You're just paying for the medications and,
exactly,
whatever.
But you don't necessarily pay your sister for that. However,
depends on your sister, I suppose.
That's right. That's right.
Okay.
However, there may be social or psychological problems in the future if it is a directed donor. For anonymous, those social psychological problems are generally less common. However, it is a different gene pool. But often, as I said, it is not easy to find somebody from somebody as an egg donor. And also, because of these potential psychological problems in the future, anonymous donation is much more often. I would say maybe 80% to 20% or 90 to 10.
Yeah, I wanted to talk about that aspect of it, the psychological, social. When it's an anonymous donation, is that a hard rule? Meaning, is there any way for a child to then later find out who their egg donor was, or is it absolutely closed to them?
It depends on what the donor and the recipient wants. So in that universal donor form that I mentioned, there is a place where they check if they would like to meet, if the child wants to meet, if they are okay to meet the child, for example. And what I noticed, often they say yes, they don't have any problem, the donors, meeting, the child.
Right. But if the donor said no, then it's closed. The child will not be able to find out.
It is closed, from our part medically, because, the donors are, their names are not there. It is all codes. However, with the advance of technology, with 23andMe, etc.,
people are finding out.
People are finding out, exactly. There is a potential that they may find out in the future.
It's so interesting.
So we don't tell them it is anonymous. They are not. She's not gonna know the donor. Donor is not gonna know them from our part. Yes, but in the future, if the child makes the due diligence to find, we cannot avoid that.
Right. But you're saying many, if not most, of the donors tend to be okay with someone contacting them later, 20 years later to say.
Exactly. They are generally checking. It is okay for them to contact if they want to. Most of them check yes.
And in your experience, because you've been doing this a while, how often does that end up happening, you think, that the children end up finding out? Or do the parents typically tell the children that they were the product of an egg donor?
They typically do. They are recommended to tell the children, because it is worse if the child finds out later without parents telling them.
Right.
And most couples are okay to tell them. I had patients, couples who said, I'm never telling.
Right.
And then in those cases, they are looking for, blood type match to make sure that, they are not, it is not found through that route.
Right.
But majority of them are okay and are ready to tell, and they are recommended to tell. There is a small minority that never.
And when do they tell the children? Is it from always, or at a certain age, or is this, when's it recommended?
It is generally, I would say always, slowly after the age of 4 or 5, once they are, not a shock at the age of 12 or 18.
Sperm donation must be easier in the sense of doing it because it's not as, painful to get a sperm donor, but they get less money, I assume.
They get, that's true. They get less money. It is less painful, for sure.
This is economics, supply demand.
Exactly. It is easier to produce sperm than to bring the eggs to the lab.
Right.
So yes, it is much easier. Sperm donation is much easier. They undergo through the same rules, though. They have to check. Sperm has, if it is anonymous, especially, sperm has to be quarantined for 6 months. So they produce the sperm. They do blood testing. The sperm is there for 6 months. After 6 months, they go back for another blood testing to make sure that they didn't have infectious disease during that period,
like HIV or something.
Exactly, HIV, Hep B, Hep C, syphilis, chlamydia, and gonorrhea. And for men, HTLV1 and 2 as well. And they are checked for CMV, cytomegalovirus 2.
Right.
So, and then 6 months later, they are checked again. If they are still negative, then it is off the quarantine. That's particular specimen.
And when parents are making these decisions about, egg donors and sperm donors, and let's assume it's an anonymous situation, is it something where they get real detailed or saying, I want someone who, plays lacrosse and is over 6 feet tall and has, brown hair? Does it get to that? Or is it like, how detailed do they choose from on their list?
It depends. And it is very different from one patient to another. The majority of patients, what do they care is ethnicity and race. Some of them do not even care about that.
Right.
But majority do. Yes, they look at their hair colors, eye colors. They look at their educations. These are all given to them as an information. But, somebody, it is rare that you are going to find somebody who is going to look for a specific attribute. It is generally general attributes. Do they look like them? If they are blue-eyed, they are looking for blue or green-eyed, for example.
Right.
But otherwise, majority of couples do not go into that much detail if they played lacrosse, etc.
Right.
However, they check their height, they check their weight,
right.
current, eye color, hair color, because these are the first attribute that someone sees.
Right.
So these are important. But otherwise, I didn't feel that, the couples are going into much detail. Although, they are doing much of it online. They go to the bank website and they are choosing from there.
Got it.
So, I don't know how much, when I speak to them, they don't go too much into detail, but maybe they do when they are at the website.
And then do the egg donors always come through? I mean, if you have a couple who's, having fertility issues and you guys make a decision, she's going to use an egg donor and she finds someone, does the egg donor then come to your office, or is it something where the egg donor is somewhere else and then the eggs get brought to your office, or is it either?
So it is, there are many scenarios. For example, if that egg donor is our egg donor, then most likely she lives in New York.
Right.
So then she comes to our office for blood work and everything.
Right.
We collect her eggs, etc. Sometimes it is possible that they find through an agency. And if it is an agency, that donor may be anywhere in the United States.
Right.
So, and then, it becomes a little bit more complicated, more expensive. But still, we prefer that they can do their screening and monitoring blood work and the sonograms at the place where they live. Right. But then they have to come for retrieval to our office.
Because if you have to freeze the eggs to ship them, then the success rate's going to be lower.
Exactly.
Got it. So you need the eggs fresh and then you inseminate them right away.
Exactly. Since we have that option, we would rather do that. In that case, of course, it becomes more expensive for the couples because they fly and the accommodation costs, etc.
Right. But if the success rate is higher, then maybe it's not more expensive.
Yes.
And what do people do at fertility centers that are not New York City? All right. So they're in a place that's more remote. Are there, if you're in a smaller town and there's, there is an infertility clinic, do all of them have their own, community of egg donors? Or in that case, do they just not do egg donation? How does it work?
I mean, if there's an IVF clinic, most likely, often, I would say, they have an egg donor program. Right. But if you are in rural areas or in places, there are places where you have to travel like 2-3 hours to go to IVF clinic, for example.
Right.
Those clinics still, collect, I believe, their donors from the local area or from agencies
and
again.
Fly them in. Yeah.
And then, of course, if they can, if the couple can afford it, yes, they can fly them in, Again, from agencies, you can get donor from anywhere in the country. If that particular couple likes that particular donor, and if they have the means,
they'll do it.
They are going to do it.
Is egg donation ever covered by insurance, by health insurance? I know infertility treatments, frequently are, sometimes are not. Obviously, it depends on exactly the scenario. But what about, for getting egg donation? Is that ever covered?
It's a tricky answer.
Okay.
So egg donation is not covered by insurance. However, if the couple has IVF coverage, so the egg donation has two parts. The donor gives the eggs, and then we fertilize and transfer the embryo to the recipient.
Right.
So no insurance is going to cover the donor part, the screening, egg collection, monitoring, etc. However, if that particular couple has IVF coverage, the embryo transfer
would
may be covered by her insurance.
That's so interesting because they would cover the woman herself to have stimulation and a retrieval and everything, but they won't cover to have her outsource it to somebody else, even though the success rate's going to be better.
No, they won't. I never heard any insurance that would do that.
And so for a couple, then what is the added cost if they're doing IVF and then whatever it is, whether they're paying or whether it's insurance, what is the added cost to them to having an egg donor?
I mean, again, it changes a lot. So now you are treating two patients at the same time.
Sure.
Not only the woman, but we have the
egg donor,
and we have the man, of course, because they are also checked, they are also undergo screening processes. It changes a lot. I cannot give you a specific number, but it may be 20,000, 30,000.
Wow. But it's a lot.
It is a lot, yes.
Yeah.
However, one thing that we do often is split cycles. Because the donors are young.
Oh, two people can use the same donor.
Correct.
And that makes sense.
They have a lot of eggs, and good number of these eggs are normal.
Right.
So we do one cycle for the donor. If they have 20 eggs, it is split 10-10 to the donors. So they share the cost and they share the eggs.
Oh, that makes sense. Okay, so that would be an interesting way to do it. And then if someone is going to have a pregnancy through IVF and they ultimately choose to have an egg donor, obviously on the plus side, the embryo will have a much younger genetic age, so a lower chance of genetic abnormalities, lower chance of miscarriage, lower chance of Down syndrome, all of these. Are there any risks to doing it? Any risks that increase by having an egg donor? Specifically, I know preeclampsia is something that's interesting that seems to be higher when you use an egg donor.
So not that I know of, honestly. I mean, we did the study for the sperm donors,
right?
And from SART database, Society for Assisted Reproductive Technology, we published a couple of years ago.
Yeah,
we did not find any difference because we hypothesized that if it is a sperm donor, for example, the woman is not sensitized. There is no prior semen exposure, or sperm exposure from that person. So maybe the preeclampsia, for example, would be higher, but it wasn't.
In the obstetrical literature, obviously any woman who's having egg donation tends to be at increased risk for preeclampsia anyways, because either she's older or IVF, and these are risk factors. Okay, but it does seem to be that if you sort of match, even at the same age, the ones who have egg donors have a higher risk. And the thought is maybe that, when you don't have an egg donor, right, the pregnancy's 50% genetically yours and 50% genetically somebody else's. And if there's an egg donor, it's 100% genetically somebody else's. And there's thought that there's some immune component to this. But it's interesting. I mean, it's a fascinating concept. So that seems to be the case. It's not a reason not to do it, but it's just one of the things. And then would you say in your experience, I was trying to figure out if the trend for egg donation would be going up or going down. And on the one hand, you would think maybe it's going up because the technology is better, and maybe women who are, in their, mid to late 40s are more, eager to get pregnant potentially than they were before, or they know about this. On the other hand, there's probably a lot of women who are in the same situation, but have now frozen their eggs from 5 to 10 years ago. And so they don't need egg donors. They're their own egg donors. So which have you seen in terms of the trends in your practice? Are they going up, down, or about the same?
I don't have such a long history.
Okay.
In REI world, I have, I would say, 13, 14 years of experience. 3 of these was fellowship. So, what I saw was an increase in demand over the years. Because if you look at the SART data, Society for Assisted Reproductive Technology, the proportion of women with diminished ovarian reserve increased over the years. It was maybe for 5% when I started. It was 14, 15% a couple of years ago. Why? Because women are delaying their pregnancies. So during that period, it increased. But then in 2012, egg freezing became clinical. It was research before that. So, but those women did not come back. Some of them, actually, I had a couple of patients, who were interested in using their eggs that they froze in 2013 and 14. But you are right. As these women come back to use those eggs, then there will not be that much demand for the other egg. However, the counterpart to that is, women are still delaying their childbearing. And not everybody is freezing their eggs. So the more they delay, the more likely that they are going to need third party for reproduction. So I guess we are going to see the data. It is not easy to speculate. I don't think it is right to speculate.
I mean, I imagine if as your egg freezing numbers go up, your egg donor numbers will probably go down, but that's a lag of about 10 years. You're meeting with a couple and you're trying to determine if, with her, is it better to, try her own or try egg donation. Aside from just the numbers, like you think it'll work if she tries on her own, is there anyone who you would advise against using an egg donor? Is there someone who shouldn't be having an egg donor, or it's basically just if they have the means and they're okay with sort of the, the social sort of whatever, to work around, then it's fine. Or is anyone who would not be?
I mean, the one who would not be is someone, for her, the getting pregnant is contraindicated.
Okay.
That would be one. But in those cases, they may use egg donor and a gestational carrier at the same time.
Right.
With their partner's sperm or with a donor sperm.
Right.
So there are all these possibilities. So egg recipients, they undergo also psychological screening. And often they pass. That would be one hurdle. If there is a major psychopathology that is discovered,
right,
this may be an hurdle.
Right.
But otherwise, if they are okay to get pregnant and if they don't have the means with their own eggs, I don't see any reason why we would refuse someone to use donor eggs.
That's great. Well, thank you so much for coming on to talk about this. It's such an interesting topic, and just that it's available and it's an option, and it's allowing many women who otherwise would not be able to conceive and carry a pregnancy to do so, which I think is fantastic for them. And it really does open up opportunities that didn't exist before, which is pretty much what you guys do every day. That's your job.
That's right. Thank you very much for having me.
Thank you for listening to the Healthful Woman podcast. To learn more about our podcast, please visit our website at www.healthfulwoman.com. That's HEALTHFULWOMAN.com. If you have any questions about this podcast or any other topic you would like us to address, please feel free to email us at hw@healthfulwoman.com. Have a great day. The information discussed in Healthful Woman is intended for educational uses only and does not replace medical care from your physician. Healthful Woman is meant to expand your knowledge of women's health and does not replace ongoing care from your regular physician or gynecologist. We encourage you to speak with your doctor about specific diagnoses and treatment options for an effective treatment plan.